It was a very dirty word. And in some states, it was actually illegal for a dentist to advertise. So that means half the patients that come in your practice and get diagnosed, they don't get it treated. They're walking around with a diagnosed diseased mouth. Most buying decisions, the vast majority, are made with emotion and justified with logic.
How do you think about implementing systems and processes to allow for people and organizations and leadership to pursue some of that consistency across their organization? Welcome back to the Dental Economist Show. I'm your host, Mike Huffaker. Before we dive into today's conversation, just a quick reminder, if you are enjoying the show, please be sure to like, subscribe, or leave a review. Your support helps us continue to bring valuable insights to dental professionals everywhere. Today, I'm very happy to welcome Janet Hagerman. She's a DSO Fractional Chief Hygiene Officer and Case Acceptance Coach. With over 30 years of experience spanning clinical practice, DSO leadership, and coaching, Janet has helped dental organizations build hygiene departments and case acceptance systems that are profitable, repeatable, and scalable. She is also the author of several influential industry guides, including Selling Dentistry, Ethically, Elegantly, Effectively, and Meetings Make Money, sharing her expertise on growth, patient engagement, and operational excellence. Janet, it is great to have you on the show today. How's everything going?
Thank you, Mike, for having me. I'm delighted. Going great. I'm happy to be here.
Awesome. Well, hey, I would love to hear a little bit about your story and your background, maybe even starting with how did you get into dental in the first place?
Well, I started as a hygienist and I worked the general dentistry, pedo, perio, all the different specialties, and I did that for years. Um, I was invited to become a dental consultant, to which I replied, there's no way I would ever be a dental consultant. And then I became a dental consultant. But I worked with groups and I worked with doing full practice management coaching. And then also at that time, this was quite a few years ago, there really was no hygiene specific coaching. And we probably had the first hygiene specific coaching program. So worked with that for a few years. And then that split up. We all went in different directions. Happy to say everybody's very successful in their own right today. But I was invited to become the director of hygiene for a group that had over 100 practices. And at that time, Mike, we didn't even have the term DSO. That expression didn't even exist. And at that time, I like to say, I know DSOs, the good, the bad, and the ugly. And at that time, they had a terrible reputation. So, but I took the job eyes wide open because I thought, it'll look good on my resume. And if I make it 6 months, great. Well, 6 months turned into 6 years. And what I realized when I got there, they didn't know what to do with me. They just knew they needed hygiene help, something. And so what I realized once I got over the shock of being in a corporate environment, which I had no idea how to work with, but once I started to get used to that, I realized I had this blank page, this blank palette to create whatever I wanted to create. So I created a great team, fantastic team. And then little by little, we started with perio because the majority of people in this country have some level of periodontal disease, as we all know. And so we started with that protocol and worked our way through many other clinical and business protocols, and very, very successfully. And I found that I just loved teaching and sharing and training and organizing. So when that gig was up, a lot of doctors had said, when you come into our offices to work with our hygienists, do you know how to sell dentistry? Can you teach us how to sell dentistry? I know dentistry is walking out the door, but I don't know what to do about it. And I said, yeah, I can do that. And they would say, but whatever you do, don't call it selling dentistry. So for some reason,
It's a
in this
dirty word,
industry,
right?
Absolutely, it was a very
Yeah.
dirty word. Well, and remember, years ago, it was unethical to advertise. You could not advertise, and in some states, it was actually illegal for a dentist to advertise. So we've come a long way. But, so I realized a niche there was for selling dentistry. So I took the, counsel of a person who had mentored me, Paul Homily, when I said, "What are your top 3 strategies for success?" And he said, "Janet, write a book, write a book, write a book." So that's where selling dentistry came from. So that was my niche for a while, case acceptance. And then I started seeing as DSOs emerge, and saw so many in that smaller space of the younger groups growing so quickly, merging, acquiring, but they didn't have any foundation in place. So you had 10, 20, 30 offices. Everybody was doing hygiene a different way. Some hygienists probed, some didn't. So you had what I call the hygiene du jour or the culture du jour, whatever culture that person brought was the culture of that office, and there was no consistency, and it wasn't good for the patients, and it wasn't good for the brand either. So that's when I started seeing fractional C-suite levels, fractional chief marketing officers or fractional chief uh, uh, even CEOs. So I thought, I've never heard of a chief hygiene officer, and there should be one. So I started working as a fractional chief hygiene officer, helping emerging DSOs create a hygiene department. So that pretty much brings us to where I am today.
Yeah, that's great. Thank you. I want to get back to the book in a second, but you kind of mentioned that earlier on in your career that maybe hygiene didn't get its due. There wasn't a lot of coaching that was taking place. It wasn't maybe as well organized as it should have been in the approach, especially across larger organizations. And it seems maybe surprising given how critical hygiene is to the health of a dental organization or a dental practice and for the patients as well. Do you think we're at a point now where hygiene gets its due, or do you think that there's still a lot of work to do?
Well, we certainly have come a long way. There's no doubt about that. But I still think that there is work to do. I don't think Heidi does get its due. Sometimes it does and sometimes it doesn't. And this has a lot to do with the situation that we're in right now. I mean, I know that COVID was one of the reasons that we lost a lot of hygienists, but I think hygiene is really hard work. One of the things that I think would make it better is if we had an assisted hygiene model straight across the board. I mean, no dentist would think of practicing dentistry without not one, but possibly two, sometimes even three assistants. I think it's silly to pay a hygienist the salaries that they're expecting, sometimes with just cause, sometimes not, to, tear their room down and disinfect and do instruments. They should be doing what they only are legally allowed to do, and then, have an assistant to fill in those other gaps. So, I think that there is a lot that we can do. I think there's a lot we can do in terms of, hygienists and dentists partnering together for co-diagnosis, and that's one of the reasons that I wrote my book, Meetings Make Money. That's one of the meetings I recommend is a hygiene doctor meeting so that eventually we get on the same page, almost like a married couple. After a while, you start thinking alike, um, so that the hygienist and the dentist are clinically, philosophically, completely congruent. Um, and if they're not, then they have a system for, how do we resolve that, uh, professionally, prior to or away from the patient. So, yeah, I think there's a lot of things that we can still do to to help some of the gaps that we have in hygiene right now. But and having said that, we've come a long way.
Yeah. Now, going back to kind of the idea of that model with the hygienist and an assistant, have you seen that implemented successfully in any groups? And from kind of a financial perspective, I can understand that if you're not having to break down the room, you're not having to do that part of the role, that there could be an opportunity to see more patients throughout the day that would thereby fund the, bringing in of an assistant. Is it something that you've seen be successfully implemented, and kind of what were the results of that model?
Sure, I'm not aware of any large groups that are doing that, although when I had that $100 100 practice group, we did it on a limited basis. Um, I'm not talking about accelerated hygiene. I'm not talking about killing a hygienist with a crazy schedule, but it has to be staggered. The schedule has to be staggered properly. It has to be a dedicated assistant, not an assistant that we're going to grab when they have extra time. They have to be dedicated. I mean, one assistant could take care of two hygienists. I had an assistant when I worked clinically, and that was over 30 years ago. So, yes, it can work if it's done right, and it has to be with hygienists that want that opportunity. I loved it. I've talked to hygienists that for some reason didn't think that they would like to work that way. So everybody has to be on board. Um, but yes, it can work. Yeah.
What do you think the reasoning would be for a hygienist to kind of shy away from that, or think that they don't want to work that way?
Well, this is what I hear. What I've heard is, nobody can really explain the way I do my education. It's almost a possessiveness about patients. Like, these are my patients. I've seen them for so many years, and I don't want to give them up to anybody else. So in my mind, it's all of our patients, the whole office, and we all work together for what's best for the patient. But those are some of the reasons that I've heard. So that's why, I mean, if somebody is really against it, then I wouldn't want to push that on a hygienist. And there's training involved. I don't see any reason why you can't take an assistant who's eager and wants to learn and has a good attitude, and teach them all the phrasing that I use, all the words that I use, and basically make them what we a mini me. So, and then how do you introduce that to the patient? Mike, I want you to know that I'm so excited. I have an assistant now, and Jane here, she is amazing, and you are going to love her. I'll still be taking care of you, but now she'll be taking over some of the duties as well. And you're just going to love her. She's wonderful. That's how you set that up for success.
Yeah, it's very much sounds very much like a perceived loss of control or loss of a part of the role, and it's always scary, I think, for people to give things up like that. Not just in hygiene, but any role really, as you kind of move through the different organizations, and you are almost forced to specialize more in whatever your core competency is, and as a result of that, other folks should be brought in to help elevate your abilities, but it's often perceived as a threat, when that's not the intent.
Yep. True. True. So that's one thing. And then just from a whole philosophical standpoint, just the way we deal with dentistry in general in this country. I mean, I think it's ridiculous that we have different state laws, and that we're not reciprocal. There's not a good bit of reciprocity there. So I think that from a political standpoint, we could make some big changes there. And I think hygienists should regulate hygiene, not dentists regulating hygiene. I think hygienists should regulate hygiene. So I'll probably get some flack there from some dentists, but um, yeah, I mean, in some states, hygienists can actually do fillings, different types of fillings on teeth. They can't cut teeth, but they can do pretty much everything else. And then other states are much more delinquent in what is allowed. So I think reciprocity would be huge.
Let's talk about your book, Selling Dentistry Ethically, Elegantly, Effectively. Why did you feel it was important in the title to put ethically in?
Because so many people in dentistry, dentists, say we don't sell. As a matter of fact, I've had dentists say you should never have named that your book that, and I well, why not? Well, we don't like to call it selling. I said, well, why is it that when I speak on that topic, my rooms are overflowing? You know, oh no, no, we want to know. We just don't want to call it that. There's this huge hang up about about that. So my point was, I'm not talking about selling anybody a bill of goods that they don't need. And my experience in dentistry, I mean, of course, in any industry, you have some rotten apples in the bottom of the barrel, sure. And I mean, if you read Dr. Mike Husband, I read all these horrible stories that Kevin's publishing about
I know,
these
right?
terrible, I know. But for the most part, my experience is that dentists typically don't err, they err on the side of being too cautious. I call it the Weight Watcher dentist. We'll just wait and watch. So we're not talking about selling somebody a bill of goods that they don't need. I'm talking about selling dentistry that is clinically needed and documented. You've found it, you've assessed it, you've diagnosed it, you've documented it. It is according to the ADA guidelines. So that's selling dentistry ethically. So at the beginning of the book, I just wanted to put that to rest so that people would understand what I'm talking about. I'm talking about selling dentistry that's needed by the patient. Um, the statistic of case acceptance in this country is 30 to 50%. So that means half the patients that come in your practice and get diagnosed, they don't get it treated. They're walking around with a diagnosed diseased mouth, and by virtue of that, whole body health. And we're not doing our job. So that's what I'm talking about when I talk about ethically.
So why do you think there is such a reluctance um, to to focus on case acceptance and increasing it with patients that have been diagnosed with a need? From my perspective, it very much seems like it's a disservice to the patient if you're not going through and helping them truly understand the benefit that will be received by the treatment that they need, and if you're not allowing them the opportunity to ask questions and hopefully accept that for their own health, it seems like a disservice. And it's not necessarily, it's selling. It is, but there's nothing wrong with selling something that somebody needs.
Many reasons. Okay. First of all, we're not really taught how to sell. Okay. We're taught clinical dentistry. That's all we're taught. Um, Many, many, many marketing studies have shown that people make buying decisions, dental and health included, but most buying decisions, the vast majority, are made with emotion and justified with logic. Now, we have that logical side of our brain, and then we have that creator side of our brain. In dentistry, we work in a little black hole of millimeters all day long. So when it comes time to talk to a patient about a crown, we talk clinical speak. And that's one of the big problems. And Mike, we talk too much. We talk too much. We're taught in dental school and hygiene school, educate, educate, educate. If you educate your patients enough, they'll accept treatment. Well, we know that's not true. Only 30 to 50% of them do. And most of the time, we get that dazed look. Um, so before we can talk clinical, we need to get to know our patients and find out what their values are. We need to appeal to their emotions. So part of my book, I go through values questions, um, asking good open-ended questions to find out where your patients are and give them a chance to talk to you. It's amazing what patients or people in general will tell you if you'll just ask them. It's better to be interested than interesting. It's better to find out more about another person than to be talking about yourself or what you have to offer. So that's the first thing, is to get to know people's values. And we don't have a lot of time in dentistry. And so I think feeling crunched for time, like we don't have time to do that. So I have very simple strategies in my book to teach the whole team how to get to know those values. So for a quick example, if I have a patient that needs a crown, I have 3 patients that need a crown. The very same tooth, for the very same reason, the very same quadrant, the very same area, for the very same reason. But I know that their values are different. I'm going to present it differently to each one of them.
What would be a difference in value? Can you give an example of that?
Yeah, the 3 main reasons that keep people from going to the dentist: time, money, and pain. So if I have, a patient who is terrified of going to the dentist and they finally come in and they need work, I'm gonna say to them, "You know, I know you told me that the most important thing to you about your dentist is that it doesn't hurt, and that's my goal for you as well. So, let's go ahead and get this taken care of as soon as possible. Because what I don't want to happen is for you to be in pain and come in here as an emergency. So let's do that on your schedule now. And I can promise you that Dr. Huffaker is wonderful. Patients love him. His assistants are fabulous. You are going to be in such great hands." That's the way I would talk to that patient. My bank president, that money is not an issue, but time is. I'm going to say, "Mr. Bank President, I know how busy you are and how valuable your time is. Let's go ahead and get this taken care." The last thing I want is for this thing to break when you're getting ready to get on a plane and go to some meeting. And then this becomes an interruption in your schedule. Let's take care of it now. We can schedule it when it's convenient for you, but let's go ahead and get it done so you don't become an emergency. So each patient, that's how I'll talk to. And then if they want to actually know about, well, what exactly is a crown and what does that entail? Then that's my opportunity to tell them.
Yeah, no, those are great examples. I love that. I love the Dale Carnegie reference too. You adhere to some of his teachings. You use people's names, and it's funny. As a side note, I played the audiobook of his book while we were doing a road trip, and I've got a 14-year-old and an 11-year-old. And my older son, every time he does anything, any activity with sports or anything, and he comes back, I'm like, "So who did he meet today? What are their names?" And he's always like, "Oh, I don't know their names." So it's like, well, I got to play this book because I need to help him understand the importance of actually knowing somebody's name and using it in a conversation. So,
Yep.
anyways, an
Yeah.
aside, but
Well, exactly.
I
Yeah.
I can see that you adhere to those principles, which I think is great.
Well,
So
that was like 75 years ago.
that's
And
right.
the
That's right.
Carnegie Institute is still going strong and people are still reading those books. So the guy, he was pretty smart.
Absolutely. Well, I love the examples of the values and how you frame the conversations according to those values. Even just in you kind of sharing that, it hits home. Like you can certainly understand how it's going to have a better impact on that patient when it's framed within the context of something that they really care about. So now if we switch to the DSO model and you're looking at an organization, and I think clinical consistency across multiple physical brick and mortar locations with different dentists and different hygienists is something that the DSOs are always striving for, but is a hard thing to achieve because you also want to still allow for clinical autonomy. And these are people that have been trained to be great at this. How do you think about implementing systems and processes to allow for people to and organizations and leadership to pursue some of that consistency across their organization?
That is a great, great question. So, I always get concerned when I hear, we allow our doctors complete total autonomy.
I saw you had a
Um,
reaction to that, so I was going to dig back into that because I was curious.
well, like, I said earlier, I've seen this, I've seen the good, the bad, and the ugly. So, I would love to say that every dentist is, just a wonderful dentist, but I've been around enough to see that there are some that clinically aren't up to standard of care. I think any group that's gonna grow needs to have some sort of a clinical leader, director, vice president of clinical operations, chief clinical officer, whatever you wanna call it, and there should be one for hygiene too. So for those 2 to get together and say, these are our standards of care. They are backed up by the ADA or the APAA, the American Academy of Periodontology, but these are our standards, and these are our best practice guidelines, so that we are all clinically on that same page. And then, having said that, in terms of implementation, one of the things that's so successful is for hygienists and doctors to sit down. I recommend them having a meeting once a month where they sit down and they look at a couple of cases, pull a couple of charts, you know, look at them, look at the x-rays, look at the perio chartings, and to be able to say, so Dr. Huffaker, this is what I'm seeing, and I would classify this patient a certain way. How do you see that? And for us to be able to start to make sure we would be so we can help each other. And it's not just about the doctors helping the hygienists with perio. It's about the hygienists. They're in the mouth longer for them to be assessing any restorative opportunities for the doctor. So poor Dr. Huffaker comes in. He's been in the middle of, some major restorative work. He comes in to do a check, and you've got to stand there and look for assess the mouth and explain it to the patient. No, I should have already done that. I should have already assessed the patient. Now, I'm not diagnosing because technically, legally, hygienists are not allowed to diagnose. Um, but I should be able to make observations and say, this is what I'm seeing. This is what'll happen if we don't fix it. Typically, this is what doctor might recommend. And then when you come in, just to be able to we do the necktie exam, which means, yep, yep, yep. So the patient's prepped already, and you're there to offer a reassuring diagnosis. Um, those are some things. But getting on a corporate level, clinically congruent first, and then being able to have a system for handing down the systems. Do you have a template? If you have a new, let's say it's oral cancer screening. Let's say we're going to start doing that. We haven't done that in the past. We're going to start doing it. We're going to use Bell Scope, whatever. Have a templated system for this is how we do new systems. First, we beta test it, then we start it. We have a protocol of this is what it is. This is why we use it. This is how you use it. This is the code for it. This is what we charge for it. And then to be able to go in, have somebody or somebodies, whether it's small and you just have one leader, a mentor person, or whether you're large and you have, several organizational assistants that go in and help implement things, clinically help keep those systems in place. And it takes reinforcement. Kids are the only ones that need reinforcement learning. Adult learning, we need reinforcement too. So it can't just be a one-shot deal. It's got to be, reinforced and reminded and repeated.
Is there any sort of formula that you would think of related to size of organization and the staffing and leadership that they need from a hygiene officer, chief hygiene officer, the clinical director? How far can somebody scale? Because I think when you talk about this with the oral cancer screening, for example, if you launch that, you equip the team in every single practice with what the expectations are. They have the documentation that they can read. You set the expectation for how they have the conversations, but then there needs to be some monitoring of compliance over time, along with that reinforcement. How can you effectively ensure that that is happening? Because what I see a lot of the times, not necessarily in dental, but just in business, is there are so many fallen projects that get launched and never have the support to be maintained over time because they're either forgotten about or people aren't seeking to go back in and coach and do the reinforcement. So what do you think when you're wanting to implement something? How do you think about the team that you would need, or the systems that need to be put in to make it successful?
In terms of the teams, I'm thinking, when I had those 100 offices, I had 4 assistants. And we also had 4 regional operational people. So each regional person was responsible for the fiscal responsibility of 25, maybe 30 practices at the most. And so my hygiene assistants worked with them for each of those regions. So each hygienist had 25 to 30 practices at the most. That's enough for them in a month to be able to visit every office once, maybe twice. Some offices you don't need to visit. And now with Zoom, you don't need it. You have the super achievers that are great. You tell them what to do. Suzanne, we've got this new thing, this bell scope. They're going, oh, that's so cool. That's awesome. That's amazing. I love it. They can't wait to jump on it. There's a small minority of those. Those are the ones that we just need to give them an attaboy, attagirl every now and then. Send them some flowers or send them some pizza or something because they just love to achieve. And then you've got the small amount at the bottom that no matter what you do, they're the clock punchers. They don't really care. But then you've got like the 80% in the middle that are all these different levels of coachability. So if you can start working with the ones that are easily coached and get them cranked up, and then start working with, and then have to deal with your bottom people. But I would say, every 20-25 practices should have a person that is a supervisor for that area. Starting with, I think one person could probably handle once you start getting close to 10, you're probably going to want an assistant, and then and groom that assistant to take over you so that you can start to be more administrative, because the skills that it takes to be a good hygienist are not the same skill set that it takes to be a leader and a supervisor and a manager. That's a different skill set. So if you could start to groom that person to take over the clinical aspects and become a mini you, a mini me, then you can start to get yourself groomed to take over what eventually will be more leadership and supervisory aspects, depending on how big the group wants to grow.
You talked about case acceptance being 30 to 50%. And, what are some of the things when you think about measuring what matters and KPIs that you want to keep an eye on that are most important for you to understand what the current status of a hygiene program within an organization is, and whether or not it's trending the right way, the wrong way, and then or anything in between?
Yeah, I knew we'd get to do it sooner or later, the KPIs. It's a double-edged sword. Part of the problem that we have is a lot of clinicians think, I mean, I can tell you I heard this a lot, and a lot of colleagues have told me the same thing that they hear. All corporate cares about is numbers, right? It's a quota. But once you understand those KPIs, it's just an amazing, amazing teaching tool and self-coaching tool, quite frankly. So you can find out what your case acceptance is. So if you have a practice and you have two hygienists, one of them, their perio percent is 65% and the other one is 20, that's a challenge. Why is this person doing so much more period than you? Obviously, our patients are in the same office. They all have the same level of periodontal disease. It could be with dentists. You could see two dentists in the same practice, and one of them is doing 5 times the crowns that the other one is doing. So, as as a leader, as a manager, as a supervisor, one of the challenges is how do you help that person come to that conclusion on their own without you telling them your number should be up here? How do you help them understand that this is an indication of, why is it? Are you not comfortable presenting crowns? Do you need help clinically from the clinical director to talk about when do we do a crown? How many surfaces do we have to fill before we recommend a crown? Or are you not comfortable doing a crown? I mean, maybe you're right out of school and you're just not comfortable to do a crown or whatever the procedure happens to be. But that's the learning tool that you need. I know when I investigated a hygienist that we had that was one of our super producers, and I was real curious about that because she's doing a lot of prophies, but not any perio. So I visited her privately and asked her through a series again of open-ended questions, help me understand why are there no x-rays in the chart? Well, I just don't have time. I'm so busy. Schedule is so slammed. So, well, how do you diagnose periodontal disease? How do you determine that? Oh, we don't have very much perio in this office. So how do you determine that? Well, if they do, then we'll take the full mouth x-rays. And so finally, and it was just the two of us. I would never embarrass anybody in public. Finally, she threw her hands up and almost in tears, she said, "And I thought I was a good hygienist." And I said, "You know what? You are a good hygienist, and now you're getting ready to become a great hygienist." And from then on, she was open to it, but she came to that conclusion on her own. So as mentors, that's what we have to figure out how to do, how to help people come to conclusions on their own about how they can be their best, see the best in people, and help them to see the best in themselves, and then figure out how to get there. Then they become more open to coaching. I think that was a little bit of a rabbit hole I got down there.
No, it's okay. It was great. I'm curious, do you have practices that are using Curidont, and what type of traction, adoption, and results have you seen with that product?
This is what I hear from the hygienists that are using it. It's magic.
Yeah, interesting.
It's magic. Yes. Oh, no, I'm a big Curidont fan. Yeah, I mean, I've seen the before and after x-rays of it. And of course, this is another fabulous way if you're using, AI assisted imaging with, the radiographic AI to be able to see those incipient caries interproximally, be able to apply the Curidont, and then 6 months later, they're gone. So that's what I'm hearing from the hygienists that are using it. I haven't used it myself because I haven't practiced for a while, but from the X-rays and the hygienists, anecdotally, that's what they love it, and it's really it is like magic because it gives us an opportunity not only to prevent things from getting worse, but actually cure it. We're curing this, and so it's a huge revenue stream, and it's great for our patients because we're moving closer and closer to preventive instead of restorative.
Yeah, I love that. One day I'm hoping to get the co-founders onto the
Oh,
podcast.
yes.
I think it would be a great conversation to have.
Yeah,
So
I'm sure you would be able to. I'm sure you will.
it'd be great. Last couple questions here. I'm curious. You've been in dental for a long time now. What are some of the things that still make you bullish? Where you're like, this is a great industry to be in.
One of the things I've gone through personally lately is dental work myself. And it's just amazing to me what a difference it makes when you have a full set of healthy teeth and you don't, and you have issues. So it's just giving me a huge appreciation for what we can do for people. I mean, when you consider the fact that not even 100 years ago, if you told somebody, "Here, if you lose a tooth, I've got this great idea. We're gonna take a piece of metal, and we're gonna literally screw it in that hole in your jawbone, and then we're gonna cover it with a fake tooth, and it's gonna be just like a regular tooth. It's gonna be perfect, wonderful." I mean, would you just shooken your head and said, "Are you crazy? That's the craziest thing I've ever heard." And now, we do it predictably and reliably. Um, and of course now um, it's been known for centuries, but now in Western medicine, we know about the oral systemic connection and how important that is. But to be able to, yeah, to make the huge changes that we do in people's lives, and the technology, Mike, that is just it's so exciting. And as we get older as human beings, we get slower. AI, as it gets older, just gets faster and faster, and nobody can really predict what it's going to look like in 5 or 10 years. And so I'm bullish on that too. I think that's amazing, and I think but it's a good opportunity for us to marry our soft skills that I teach in selling dentistry, case acceptance, with the technology that we have. Because think about this: most people walk around with their devices, communicating with emojis, and then we expect them to sit down and have a many $1,000 conversation with somebody. So we definitely all need to work on our art of communication. But I just think, yeah, the technology is real exciting.
Absolutely. So, last question, where do you go to learn? How do you stay on top of either the latest trends or, for your own entrepreneurial pursuits? Where are you looking to continue to grow and learn and incorporate new things?
Well, I'm a big reader. I read all sorts of stuff, whether it's general business or, we've got Brian Lanskin, Laskin. Yeah. He's written a couple of, yeah, he's got some, I read his first book. His second book is just out now. So I'll read that. Keep up with, for group dentistry now, Bill Newman for sure. I remember walking through him and with Bill Newman and him telling me about this idea that he had for group dentistry now, and it's great. So I would say you got to be a reader, and keep up, with the journals and then podcasts. I mean, there's just amazing podcasts.
Awesome. Janet, thank you so much for joining. Really appreciated the conversation. It was great to have you on.
Thank you, Mike. It was my pleasure. Great questions.
Thank you.
The Dental Economist Show is brought to you by Planet DDS. To find out more about how cloud-based dental software by Planet DDS helps unleash dentists and their staff to focus on patient care, visit www.planetdds.com. Stay tuned for upcoming episodes by following wherever you listen to podcasts. Thanks for listening.